Okay, well, good morning, everyone. Welcome to the public board. I've got nothing particular to say as opening, apart from just to welcome everyone who's here today. Are there any public questions, Julie?
No, we didn't get any questions.
Okay, let's move on. Apologies.
Mahmood and Mian will be joining us about 12:30.
Okay. Declarations of any other business for the agenda? No. Declarations of interest on the agenda items or the register? Minutes of the meeting of the 8th of December, 5.1. Any corrections, please? No. Action log and matters arising 5.2. I don't think there's anything outstanding, but if anyone wants to raise anything. Yep. Yeah, okay. So let's move on to the next section, quality item 6, and welcome Alison Salvadori, who's going to talk to us about a patient story, mental health, and the impact of COVID-19. So Alison, welcome.
Good morning, thank you.
The floor is yours.
Thank you. I'm just trying to share my screen with you. Everybody see that?
Yes, thanks, Alex.
Yes.
Okay, so yeah, good morning. So I'm Alison Salvador. I'm the head of talking therapies and mental health access services and a consultant clinical psychologist. And the case study I've brought is one of my patients within talking therapies who is also works in the NHS. And it's a story of his recovery from what we're calling long COVID. So it's also called sort of long COVID syndrome. Yes, this is his story. So just a little bit of context. Talking therapies went just to completely remote service at the beginning of the pandemic. We've been seeing about 2,000 people a month, and an increasing proportion of those are from NHS and care staff. At the moment, we've got about 300 patients from the NHS or care staff currently in the service, of which this patient, who I'm calling Peter, is one of them. And my particular interest is in clinical health psychology, and this patient was referred to me by a colleague who knew my area of expertise. And in fact, he was the very first patient I think we had in talking therapies who presented with long COVID. He has given permission, I should say, for me to use his case story for teaching. Okay, so what I'm doing in this slide is just giving you some of the background. So patient I've called Peter. He's a 35-year-old. He works in a non-clinical role in the NHS and is a sort of fairly senior manager, not within our trust. In terms of health psychology, we would understand somebody's health or illness being in the middle of a mixture of psychological, social and biological factors. So when I'm presenting his history and letting you know about his story, I'm going to reflect on those three areas. So the problem that he presented with was he had suicidal ideas. He had COVID very early in the pandemic and had been in hospital for a couple of weeks just on oxygen. He wasn't ventilated. But when he came out, he had ongoing fatigue, insomnia, terrible brain fog. He felt very hopeless and had considered dying by stepping in front of a car. He felt very guilty that he couldn't be the family man and the sort of NHS professional that he wanted to be. And he had a sort of image of himself as permanently disabled in a wheelchair with a sort of blanket over his legs. He also had, he was very frustrated that he couldn't do what he wanted, and he had health anxiety. So he was very, very anxious about getting COVID again. In terms of his social history, he's a family man with 2 young children and a good marriage. He felt an husband and father, and his sort of closest friends were abroad, so he didn't really have a lot of support apart from within his family. So biologically, he had covering from the COVID in March. but he had a lot of very, very strange sensations, so neurological symptoms. He'd lost his sense of taste and smell. He had some word finding difficulties, and he was really worried that he'd got dementia from having COVID. And in terms of his psychological history, he'd be bullied at school for being a bit different, and this was really very key to the sort of treatment going forward. They had a lot of beliefs about not being a good person, and having to be, his parents were sort of very driven perfectionists, and that's something he sort of emulated. So the treatment, one of the main treatments we give in talking therapies is cognitive behavioural therapy. This is just a little bit of context again, that we, in terms of common sense, we often think that a situation leads us to have emotions and certain feelings like depression or anxiety, but cognitive behavioural therapy would say actually it's the way we think about things that then make us feel a particular way and give us physical symptoms and make us act in a certain way which keep the problem going. We often talk to people about it's like digging to get out of a hole, that you just make the problem worse, and that was certainly the case with Pete. This diagram is sort of a mark of psychology, really. It's a formulation. So this is something that Peter and I worked on together to understand his problem and what kept the problem going. So we could see that his past had sort of been rumbling away in the background, sort of helping him in some ways be a great NHS professional and do a great job. But when COVID struck, he was this idea of if I'm not perfect, I'm broken and vulnerable was really sort of running him and what was causing the depression and the anxiety. We looked at ways that it was kept going, for example, with these images of being sort of wrapped in a blanket and having to be very careful with himself, sort of worrying about what ifs, so always sort of imaginary problems. What if I don't recover? What if I'm disabled? What if I've got dementia? Talked about catastrophizing, so thinking the worst case scenario, like I'm losing my marbles. This is a sort of an amusing phrase we use, masturbation. So he had lots of I must do this, I must do that, I must work, you know, 40-hour week, I must be able to cycle 20 miles a day, which is what he was doing beforehand. We looked at the way that made him feel, and then the sensations that he was getting in his body. And there were lots of behaviours that were keeping the problem going. So he'd really immersed himself in COVID news. He had alarms set on his phone with the latest update and on his watch. He was constantly monitoring his physical sensations, and he was calling them symptoms. We turned the word round to use sensations, looking for reassurance, really pushing himself far too hard and trying to get back to work too early, and sort of avoidant of anything like any particular food types and alcohol and coffee, and then sort of a pattern of boom and bust. He was either doing nothing or he was doing loads and loads and wearing himself out. So we worked at all those over about 16 weeks, 16 weekly sessions of 1 hour. And these are his scores of what happened during that time. So you can see he went from being sort of on the border of severely anxious over time to within sort of healthy limits over the course of about 3 to 4 months. And his depression scores also dropped quickly. And within a few sessions, he was risk-free in terms of suicidal thoughts, and it sort of improved very rapidly. So he started being able to work again and exercising within normal limits. He's up to 8 miles a day now. His role in the family was sort of restored, and he was able to play with his kids again and enjoy being a family man. When we were reflecting on what was helpful for him, he thought it was really good to look at the what ifs, so the sort of unanswerable questions that he was asking. We also spent a long time looking at the imagery of him being in a wheelchair and what that meant, and how in some ways he was already behaving to himself as if he was in a wheelchair, treating himself so carefully. We looked at the importance of saying sensations rather than symptoms, and also of reducing jargon. So he'd done a huge amount of research on long COVID and used a lot of words that weren't really supporting him. Like instead of saying he was tired, he'd sort of say, I've got post-exertional fatigue or post-viral malaise, which were keeping him very stuck. And the last few sessions, we looked at what being good enough meant, and how good enough really was about for him living to his values rather than being able to, you know, give a 2-hour presentation perfectly with his work, for example. We also worked on the Staying Well plan, and I've seen him twice since we finished therapy to make sure that he's carrying on with some of the behaviours that we looked at. And as part of his recovery, say he's agreed to be an expert by experience and help teach other psychologists and support people with long COVID wherever possible as well. So that's the end of my presentation, and I'm happy to take any questions or reflections.
Alison, thank you very much. That's a most interesting presentation. I'm sure there'll be some questions. I've just got something which is about sort of early intervention. This is arisen because this person has had long COVID and, you know, been unwell for a while. Are there more things we should be doing either for our staff or for the wider public to try and help people right at the beginning of some of these things, to sort of preempt the problems that arise by giving them helpful advice? I don't know. What's your view?
I think that's a very good point. We're actually now working into the 2 long COVID clinics in our area. So one in the west and one in the east have been established, and we've got talking therapies practitioners linked into both of those, and to pick up people early. And we're looking at writing a sort of group intervention at the moment, so that people with this type of problem can share amongst themselves what's really worked for them. We're also Talking Therapists is very involved with the staff support service. So actually we are assessing staff at the moment who are presenting. We're doing a rapid assessment and treating them in much the same way, applying the same techniques of demonstrated in Peter's story.
Thank you very much. I think several hands up. I think Naomi, and then Aileen, then Chris.
Thank you, Chair, and Alison, thank you so much. A very compelling story. It strikes me that you know we're dealing, or you're dealing here with a new disease, a new condition, which the world hasn't seen before, and yet sort of happily, if I can put it that way, you seem to be deploying a tried and tested technique. So something that's been used historically under different circumstances that works. Yeah. Is that right? Have I got it?
You have, absolutely. So I think as a health psychologist, we would always say that the health, as in the first diagram, is a mixture of biological and sociological and psychological, whether the illness is diabetes or cancer or long COVID. There we often see a similar pattern. So somebody who's depressed will sort of perhaps take to their bed and not do the things that usually keep them well, like seeing their friends or going to work. And somebody who's anxious will avoid the things that they're frightened of, or pay close attention to the symptom or sensation they're frightened of. So it's the same situation, but with a different diagnosis.
Yeah, thank you. And just, if I may, by extension, you're clearly deploying something that has worked in this case, and one might, you know, quite easily suppose that it would work in the same way on another individual, but with, you know, with the modifications to suit that individual. Yeah. So yeah. I'm interested to hear from you how this this technique is being shared more broadly. You know, this is clearly something that we've done for an individual within our trust. Yeah. Yeah, it'd be of huge interest in a broader sense.
Yes, so IAPT have the National IAPT Service have put on a series of webcasts and webinars that have been attended by over 4,000 NHS staff to teach, to sort of share learning, including from within our trust. With other practitioners in IAPS. We're expecting that that's where the majority of the sort of Peters are going to be referred to, with this mild to moderate anxiety and depression in the face of COVID. IAPS services are now funded to have 30% of their patients with long-term physical health conditions, and the staff have been trained appropriately. So we're very sort of ready and willing, and sort of so the knowledge base is there. And we'll also receive some funds for specialist supervision in this area. Mm-hmm. So myself and other colleagues will be sharing our learning through those methods.
Thank you. Incredibly valuable.
Thank you, Naomi. Aileen?
Yeah, hi. That was really, really interesting and insightful story. Thank you so much for sharing that. You said that you were setting up a group, or he set up a group that they can share people that have had similar experiences. Are we able to do anything for I mean, we've had a couple of talks about carers as part of our meetings, but what about the people around them that can actually share and help their experiences? Do we do anything for them, or?
Not formally at the moment. The sort of groups that we're thinking of setting are sort of multidisciplinary groups in the context of the long COVID clinics. So we're working with, for example, physiotherapy and OTs at the long COVID clinics to look at whether a sort of cognitive behavioural therapy based group can be set up as part of the long COVID service. At the moment, in terms of carers, it's very much a sort of case-by-case basis of when we work, advertising what we do. And for example, we've at the moment we're leafleting all the vaccination clinics and advertising what talking therapists can do and what kind of trying to extend our reach that way. But I think that's probably a gap at the moment, would be fair to say, Aileen, in terms of carer support.
Thank you.
Thank you, Aileen. Chris.
Hi, Alison.
Hi.
Well, having a psychologist for a daughter who's who's in your team, and also having been a talking therapy client off and on over many years, I've thought about this quite a lot. And my thinking, such that a non-psychologist can have some thinking about something like this, is whether you call it long COVID or you call it something else, the impact of COVID is going to be much more, you don't have to have had the disease itself to have quite significant psychological impacts from COVID. I've not had it, but as someone who, shall we say, whose core problems have always stemmed around agoraphobia, I know that having spent a year locked up, I know where I'm going to be when this all turns around. And I think that you are going to, I won't say suffer an explosion of demand, but I think you probably are going to suffer an explosion of demand. And I know that we've got as many psychologists as we've got, and we can't grow some more. So I wondered, you can't clone yourself or your team, Alison. How are we going to meet the needs of lots and lots more people who are suffering, but perhaps don't come under the banner of having spent 6 weeks on a ventilator?
Yeah,
it's going to happen.
It's very much being thought about, Chris. So we've done lots of modelling. There are various sort of models in circulation. I think we've tested most of them. All of them really say we should expect a 30% increase in referrals over the next 3 years. And we have done models sort of showing what that means in terms of therapy hours and therapists. And we're having talks with the national team and NHS England about our requirements. And one of the things that we're sort of flagging up, as you say, is we can't clone our therapists. We can make our service as efficient as possible, which we are doing. But an IAPT therapist takes a year to train somebody. And we've had sort of various bits of funding through for extra training places, which we've jumped at, and we're getting extra people into the system. But it is going to take time. But at the minute, as I say, we're doing pretty well at the moment. And we've had a sort of experience of our referrals being suppressed during the pandemic. Yeah. So we have had scope to take extra people at the moment. So yeah, it's very much being thought about and planned for, and very expected.
Thank you.
Thank you, Julian.
Thanks, Alison. Really enjoyed that great presentation this morning. Thank you. I had 2 questions, and Chris has asked one of them, which is great, about the kind of future. The second one was what's the cut-off point to go into a long COVID clinic? So, for example, your client, he wasn't pretty inactive when you got him, but it was basically psychological therapy that helped him get into the position on the graph that you showed us at the end.
Yeah.
Do you think we may send people to sort of those clinics that they've got for no good reason? Who decides if you go to a clinic and have a bit of psychology, or who decides whether you just get psychological support? What's the criteria? Are we playing by ear?
It depends on their referral route, really, Julian. So if they're self-referred to us, we can very quickly screen them and get them into sort of psychological treatment for long COVID. If they go via the long COVID clinics, then it's a bit more involved. I've got a better understanding of the one happening at the Royal Berks. Worked quite closely to set that up, and essentially the patients are can self-refer or come via their GP. They get a batch of questionnaires through the post, and then they fill those in, and one of those includes a screen for anxiety and depression. And depending on the results of what they're scored, then there's a sort of weekly triage meeting. And then they're triaged into, for example, going to see a cardiologist or a respiratory therapist, or coming into for an assessment in talking therapies. So they're being picked up like that. But it's, yeah, mass sort of screening. And they actually haven't had a huge amount of referrals that way as yet.
No. Okay, I'm interested because I think the same person referred in to different places could end up in a different place.
Absolutely. Yeah. I think as well, GPs are, we've done a lot of work with GPs over the last couple of years to sort of skill them up to recognise that what a mental health problem will look like in the face of a long-term physical health condition. That's been very difficult for them to get their head around. They either think they're sort of, when their patient is put in front of them, they sort of tell us, they think, okay, are they mentally ill or have they got a physical health problem? They sort of don't often say, and they've got a physical health problem.
That's really helpful. You've got a GP who's going to be asking a question in a minute. We'll see what he thinks.
David Buckle.
Hi, Alison. Yes, I was going to say how I completely agreed with you until you said that last statement. So where I completely agree is your holistic view about illness. And I have an observation. I mean, as a GP, I found it relatively easy if somebody had a physical condition with a beginning and an end, and a lot of patients with COVID will fall into that category. I found it such a different issue if it was progressive illness lasting a long period of time or all their life, or indeed, like the elderly, have so many conditions. So as soon as you hit one on the head, guess what? The next day, something else pops up. So, then it becomes a completely different sport, because it is your job there to deal with the oncoming physical illness, the subsequent mental issues, or do you try and do both? And it just gets very cloudy, I think, at times. But my question is a bit more specific. We know that COVID is unique physically in some ways. For example, the effect on smell is quite interesting medically, and has issues. We know that COVID is distinct from a mental health perspective. Just look at the scale of it. And as Chris and Naomi have alluded, there's all sorts of elements that make this different. But it's a rather targeted question. I'm actually not convinced that COVID, from a mental health perspective, is actually showing any new features or signs of problems. And the reason for asking that question is, if there is a unique thing, our normal way of dealing with these might not work. And what I think your presentation has shown us is that the normal way of dealing with these things, whether it's COVID or any serious illness that bounces you into hospital, can be dealt with with the tools we have.
I completely agree, David. I think it's, as I say, it doesn't really, from my perspective as a health psychologist, it's always about the way somebody appraises what's happening to them, rather than what is actually happening to them. It's what they're making of it. So and in this case, and that's quite a classic, the person suddenly feels incredibly vulnerable, and it's how they try to manage their vulnerability that leads them into problems, in the way that I sort of demonstrated on the patient's formulation. So I completely agree with you. I don't think it's anything new at all. I think it's a different trigger to an age-old problem, which is how do we handle ourselves when we feel frightened and vulnerable?
A different trigger, a different scenario, but the same beast in many ways. Yeah,
for sure.
Thank you very much. David Townsend.
Hi, Alison. Thanks for the
Hi,
presentation. Hi. it was a few months ago, but I've spoken with 3 of our staff that have experienced long COVID, a couple at Prospect Park and a district nurse. And at the time, we didn't have these clinics in the East and the West set up, and they were saying, where can I get help? And all I could tell them at the time was, there's a lot of really good self-help material, and I think we've got links to that on our website. So I suppose my question is, I'm a bit behind. I don't know whether our staff know how to easily access talking therapies, because when I go to Prospect Park, I don't see posters there. I don't know whether the staff would know that they could access your services or not. Do you know whether that's the case, or whether we've done anything around promoting it internally?
We have done quite a lot, certainly in working with Bridget Kamal and the staff support service. And in fact, the staff support services comes into IAPT at the moment. Perhaps there is more we could do, and it might be, and I'm always very happy, and I have a lot of managers giving me people numbers or names and sort of arranging assessment for them. It might be that we could do more. It might be, for example, we could do a similar presentation at the meetings that are online. I'd be very happy to do that and say, this is the kind of help we can give you.
Or even some of the posters that I know you've got a lot of really good support, publicity material, haven't you? Getting some of that up around the trust, on notice boards.
Yeah, I mean, as I say, we're giving out flyers at the vaccination clinic at Wokingham at the moment. I think I could have a chat with Bridget and see if we could do some more targeted posters towards staff. Often there are sort of confidentiality worries that we can reassure people about as well. But as I say, we have a lot of BHFT staff being treated in the service at the moment.
Yeah, if there are some posters up and about, there's definitely one in the men's toilets at Fitzwilliam House at headquarters. We need to get a few more out and about, Alison. And I do think actually your presentation was very reassuring. It might be helpful at some point to showcase it, because it was accessible, understandable, and reassuring, I think, for people in that category, so they know that there's somewhere they can get that level of support. I think it would be helpful, and also I think it would quite be helpful for people to see it, so that if people are working with people, because we've got people working with hundreds of thousands of people at any one time who may also be experiencing long COVID, that they know where they might be able to refer to as well. So there's a kind of double win there, I think.
Yeah.
Alison, absolutely fascinating presentation, really, really impressive, and thank you to you and your colleagues for all you're doing. It's and also thank you for an excellent and clear presentation. As Julian said, it was very easy to understand and get the impact of it.
Yeah.
Just before we let you go, I just got one sort of observation, which is, apart from saying how impressed I was, but about your point about the future. I think Chris raised the demand issue about maximum. And I just wonder, we ought to reflect on whether there's things we can do with self-treatment through online things or something, maybe improve those or whatever, to help manage the caseload, because there's going to be something where you perhaps triage people and they can start on one, and whether that needs some more work, because we don't want to leave people without any access to some sort of therapy, do we?
Yeah. Thanks, Martin. So you might be familiar with the modelling talking therapies. It's a sort of stepped care service. So people come in at step 2 and have a sort of small amount of an intervention, and if that doesn't work, then they get stepped up something bigger, and sort of face to face. And we use Silver Cloud. You might be familiar with so Judith Chapman, my predecessor, did a huge amount of work with setting up Silver Cloud, which is online CBT. And recently, we used to have a sort of set number of licenses, but now we're going for a population approach for Silver Cloud. So we haven't got a limit on how much we can use it. So at the moment, we've got a project to extend that to any patient who refers into the service. We will start them on Silver Cloud, so that they can start to understand the principles of CBT and get some help that way while we're waiting to get them into treatment. So that's one of our approaches, is to make much better use of the digital resources that we've got available. And I say at the moment, we're still managing to keep within our waiting times and see people as rapidly as we were. So but we are keeping a very close eye on it. We've got lots of plans to mitigate waits for treatment.
Alison, thank you, very reassuring, and thank you very much again. I think we've got to move on, but you can tell by the number of questions you've got, which is a very, very absorbing issue for us.
Welcome.
Thank you very much. Thank you, Alison.
Bye, Alison.
Thanks.
Well, that was the most impressive session, I thought. But we need to move on. 6.1, the annual community mental health survey report. Debbie.
Yeah, I'm really sorry. I got kicked out at exactly the wrong time there, didn't I?
It wasn't me. It wasn't me.
Someone kicked me out. So the annual mental health survey, it's quite retrospective. So it's based on people that would have been in the CMHTs in Q3 of 1920, and then they're asked to fill out the survey. Well, it would have been smack bang in the middle of the first wave and lockdown. So nationally, it's recognised that although people are asked what their experience was like around about September to December 2019, they're very likely to have shared their experience during the middle of lockdown, which of course was when models of care were being changed quite dramatically for them, and a lot of people were being seen online rather than face to face. So nationally, it's really being recognised. It's probably not particularly comparable with usual years, but nonetheless, report is here, and we share the results as we always do with CMHTs, so that they can help with planning and service improvements. And take that into account, as opposed to doing an action plan specifically around anything that flags in this one-off report. And I didn't really want to say anything else really, and I'm happy to take any questions.
Okay, I think you've given us some steer about the value of discussing it in depth at the moment. But if anyone's got any questions, I just got one observation, which is not really about the report, but about one of the questions that's asked in the report, which is about, did NHS mental health services give you any help and advice with finding support for keeping work? And it seems to me that it just struck a chord that going forward, there's going to be a lot of people who are going to need to find new jobs, and that's going to impact on their mental health, I'm sure, at least some of them. So it seems to be a factor that's really important, that we help people as much as we can, or we get the system to help people as much as we can to restart in employment. Chris.
Yeah.
Hi, Debbie. Just a quick one, really. I was, you know, and I'm not going to go into the weeds of it, but I was struck by one of the tables that showed that the population that we serve is both, on the one hand, quite significantly younger, and on the other hand, quite significantly older than the average. And actually, the bit that's in the middle is where we have perhaps less demand. And I wondered whether that was, whether that struck anybody else, because clearly that has implications for service design, and it has implications for the demand side, because it's at those two ends of the scale where we see perhaps disproportionate demand. So I was just sort of struck by that. Or
they're the people that filled out the survey.
Yeah, it could be.
Because you think about you know, just under 30% of our patients who were eligible filled it out, which is about normal. Perhaps the slightly younger and older were more inclined to fill it out. I don't know, Chris.
But that's disproportionately in our trust relative to all trusts.
Yeah.
And
yes.
I, you know, you either take these things at face value, or you think they don't have any value. And I suppose I just looked at it and thought there might just be something to think about there. If we do have rather more demand down the bottom and the top end, then that might say, you know, does that say something about our population, our services, or what? You know, and I'm not looking for an answer now. It just felt to me like, you know, if we are going to look at this, you know, do we take it seriously and think, you know, having, you know, 10% more people at the bottom end and 10% more people at the top end, does that have implications for us that we should be thinking about?
Okay, thank you for that, Chris. I think probably, Debbie, we might just move on to your next paper, which is the Patient Experience Quarterly Report, if you wouldn't mind.
Yeah.
6.2.
So, yeah, thank you. This is our usual quarterly report. Unlike Wave 1, complaints and ombudsman processes have not been suspended during in Wave 2 at all, and we've continued to gather patient experience information via a variety of methods. The friends and family test has just started to be nationally collated again in January, although we did start collating it again during this quarter, and I would say we've had quite a low uptake. I don't think it's been top of people's minds, so we're doing some work on that to really get that up and running again now that it's being nationally reported again. Nothing in particular I wanted to draw out. MP inquiries are back to their normal sort of level. We've had slightly less formal complaints over Q1 to Q3 this year than we did last year. It'll be interesting to see if that's maintained or if that's a bit of a COVID impact. Quite a lot of NHS Choice feedback this quarter, which is really good to see some positive, as well as historically what's usually used on that platform is negative comments. Say a good amount of feedback from various sources, hopefully included again in the report this time to give you a more balanced flavour than just all about the complaints. The only other thing I just wanted to quickly update on was the new patient experience tool. We're at the process now of awarding the contract, so the calling off period is finished, so we'll be able to progress with that soon, which is brilliant news.
That's
so
very good.
Other than that, so happy to take any questions.
Thank you, Debbie. And it's certainly good news about the new patient experience report. Thank you. David Buckle.
Thanks, Debbie. Yes, I've read the report, thank you. And I think it's a bit difficult to know with COVID going on what to read into the report, but it's still all the same, still really good to have it. You just mentioned NHS Choices, and I noticed the comments on NHS Choices. My sort of observation with NHS Choices is that it's a select group of people who use it as a method of feedback. It's still feedback, but it doesn't represent the population as a whole. And certainly there are times where it's seen as a good opportunity to don't get mad, get even is the sort of comment I might have. However, that doesn't mean they don't have valid points. I'm just saying it's not a cross section of the population who respond to it. One of the things that I noted is in surgery is that spontaneously patients would say occasionally nice things to me as their clinician. Even more often actually would say very nice things about staff, reception, that sort of thing. And that's incredibly welcome. That doesn't really cut the mustard when your CQC come in and ask you about patient comments, because it's a verbal thing, and I know we do our best to pick up all compliments. So I'm sorry about the preamble, but I'm getting around to the question about, do we ever encourage people to go on NHS Choices? Because if somebody says something to me about the quality of my staff, in many ways, if they really want to say thanks, it's so much better if they go onto NHS Choices and say it so that people can see it. And I just wondered what our approach to NHS Choices is, or perhaps we don't have one.
I think probably the latter, if I'm really honest, David. I certainly don't think we have a strategy for encouraging people to put in writing compliments and things, but I wouldn't say that services actively encourage them to use the NHS Choices platform, if I'm really honest.
It's just something to think about. I mean, if we encourage people we should be trying to document or record or be aware of all complaints and compliments, shouldn't we? So it would be another option for people.
It would.
Okay, thank you. I just got one thing perhaps before we move on, unless anyone's got anything else, which is just an observation. It talks about the recording of ethnicity data for all complainants, and I know it's a sort of in progress, as it were, but I just, it's something we do really need to push on with, don't we, so that we understand the diversity of our complainants. Anything else before we move on? Okay, executive reports, item 7. Normally we just take questions unless Julian wants to say something particular.
No, thanks, Martin. We'll just take questions if that's okay.
Mark.
Yes, Julian, on the flu vaccination and the percentage take up on that, do we know if there is any correlation between those staff declining a flu vaccination and any staff not accepting the COVID? Is it the same cohorts, or are these two different groups with different reasons?
I don't know, Mark. I don't even know if we're allowed to do that, but Debbie will enlighten us all.
Well, I'm not sure about that, but so I certainly know from talking to people, there's definitely a crossover between the people that wouldn't. So some of our areas that are lower in their flu uptake are the same areas that are lower in their COVID uptake. So although I haven't got anything scientific around that, my feeling is that there is some commonality between the two. Historically, we haven't gathered data around ethnicity in terms of flu uptake, but we will be in a better position to do that from this year moving forward, because we're going to be using the same booking system that we've used for COVID for flu probably next year. So it will give us an ability to do that much more easier than we have done in the past. So I might be able to give you a more definitive answer when I'm reporting next year.
Thank you.
Okay, David Buckle.
Well, Mark, I've seen no evidence on this, but I mean, I think it is, my experience was quite clear, is that there is a smaller group of people who are vaccine hesitant and they categorically refuse the whole lot. But actually it's a bigger group of people who are vaccine hesitant and can be swayed when they view the risk. So I think you could argue, couldn't you, that it's relatively reasonable not to have the flu vaccine. And I think I've heard people say this because actually I'm not going to catch it because I'm in lockdown, but actually I'm seriously worried about COVID because it's so rampant. But so I think there will be a small group who have rather more nuanced fears. So we just need to tackle that, don't we? Because it's important that people have both.
Absolutely.
Very good, thank you. Anything else? I've just got one observation. Oh, sorry, Julian.
I was just going to say, well done. We some good stuff in here sometimes, and we pass over the good stuff. Item 4, I think there's only 2 trusts in the country that have been accredited around that, and it was quite it's not just a sort of rubber stamp thing. It's a big exam and a lot of tests you have to go through with a high bar. So Debbie's team and colleagues have done a really good job, and hopefully that approach will really help in terms of our processes, in terms of the culture of the organisation and the experience of those on the receiving end.
You're quite right, Julian. Naomi.
Julian beat me to the punch. That's where I was going with it. I didn't want us to move on without that acknowledgement.
Thank you very much. My point right at the end on page 53 was just about the method of delivering services, whether face-to-face or online. That's one of those things that we need to sort of keep track of, won't we, at the end of this pandemic, as to what sticks and what doesn't stick in terms of the channels for communication. Julian, thank you very much, and thank you for putting out the key points. Finance report, item 8. Alex.
Thanks, Martin. So to the end of month 9, which is December, we have a position that's characterised by doing better than planned on our underlying position before COVID, and COVID costs being higher than planned, primarily due to us not forecasting and not being required to forecast second surge COVID costs back in October. Our support to the second wave has increased our COVID costs quite significantly, and that's across a range of mental health placements or out of area placements, and that's driven by wards being closed to admissions due to outbreaks and general COVID related demand. We're expecting a level of OAPS, but not to the level currently. We're seeing around 15 still persisting in January and February against this position. So forecast view on COVID is pretty robust. I think what I'd want to just bring in is the kind of system view in terms of our position. So although we'd set a before annual leave provision deficit plan of 1.8 million, and we look a bit better than that, well, actually being in deficit as part of the Bob system, when the rest of the Bob system at month 9 is looking like it's going to be in surplus, has led us to a pretty mature for the Bob system position around us not being in deficit by the year end and being supported to close that deficit. So I'm expecting, guided by region, that our deficit of 1.5 million driven by COVID costs is going to be resolved in the forecast. That will leave the allowable annual leave accrual, and we're seeing some review happening nationally about that potentially being funded as well. So that would just leave us the impairment risk in terms of an I&E technical pressure, not an operating pressure. So there's some upside on this forecast is the nutshell, and supported by the system surplus position in Bob.
Alex, thanks so much. Any questions for Alex? Alex, while people are thinking, I rather miss the graphs you used to present about staff numbers in various categories.
Mm-hmm.
You know, nurses, physios, admin, all those sort of things. Is that just paused because of the COVID issue, or is it? Have I just missed?
We shortened the report. We can bring those back in, Martin.
Yeah. Well, I mean, at an appropriate time. I think they ought to come back at an appropriate time, but maybe not now. Is not the time. But, thank you, Alex.
The other issue I'd highlight is our working capital position with NHS Property Services is resolved. We received a payment this month, so that position will improve on cash.
Okay. No, I think you've sated people's appetite for questions on this. Performance report 8.1.
Yeah, again, happy to take questions, as my exec colleagues will be. Just looking at the month 10 results, and I think we are seeing some pressure on the safety metrics in terms of breakthrough around falls, self-harm, and linked through to the COVID surge. So we'll want to keep those trends under review. But at this stage, the position is well understood. Debbie, you may want to comment around the falls particularly, because we're seeing that trend go up.
Yeah, we're noticing. So we've definitely seen more patients COVID positive in our wards in this wave than we did in wave 1, and associated that particularly in our older patients is quite a lot of delirium, confusion, and it's definitely leading to more falls amongst a small cohort of patients. So it's well known on the wards, and they're looking at ways that they can mitigate that. But it's noticed nationally. It's something that quite a lot of my colleagues nationally have commented on.
Okay, Debbie, can I just ask you a question about falls? In the cover sheet, it talks about falls in community and older adult wards. It says 77% of falls were unwitnessed. How do I interpret that? Is that because of pressures on staff, high numbers of patients? Is it?
So most, if you think about a ward that's got 30 patients and 8 members of staff, the vast majority of our falls tend to be unwitnessed. So they might be in a toilet, they might, behind a closed door while someone's doing something. So I wouldn't interpret it too deeply. Actually, it's the way we record it. Are they witnessed, or was somebody actually physically with them and they still fell, or was it a fall that happened when someone was doing something away from a member of staff?
Thank you. And I've just got one other thing, Alex, if I may. I think it's for David, but about the length of stay in mental health. We know there are lots of pressures. Is there anything, David, you could add about length of stay? Is it David, I ask?
Yeah. So it's work that we continue to have using QI methodology at Prospect Park, looking at length of stay. It's obviously complex because it's linked to social care and what's available outside, as well as having good treatment while people are there. And obviously with the COVID position, staffing position, and the numbers that we've got teams. Our teams are stretched, and so are the social care teams. But it remains obviously a key priority for us, because if we can tackle the length of stay, and we know from a benchmarking point of view there are opportunities for us to do that, that we can increase our capacity, and then that will ease the pressure on out of area placements, which we know both financially and from a patient outcome point of view would be a good place to be if we can get that reduced down. So it remains a key priority, and we continue to work on it.
And on out of area placements, the numbers have gone up dramatically, haven't they, in the recent months?
Yeah.
Can you give any sort of reassurance about what might happen over the next few months? You know, is there a feeling as to things are in place to, or is it just a question of how demand goes of patients, I suppose? Perhaps it's a silly question, but
yeah. So I think we're hopeful that the numbers will start to come down, but I think they'll come down more slowly than we would have seen when we would have had these peaks traditionally. And that's because we're still managing COVID outbreaks on the wards, which is limiting our capacity. And we also are seeing high level of acuity within our mental health services, and that's obviously appearing within our urgent care services in our bedded services. And also nationally, it's the same problem, and it's very difficult to get hold of an out of area placement bed. So when we do have beds available, at the moment, we're not repatriating everybody that we could, because we want to maintain some capacity for those that might need it the next week. And if we lose a national bed, an out of area bed, if we need it next week, the chances are it's not going to be there. So we're repatriating much more slowly and more carefully in order to maintain capacity going forward. And that's why the numbers of sort of 14 and 15 have been fairly consistent now for about 4 to 6 weeks. It's because of that position of our capacity and us needing to manage the lack of availability nationally to get hold of out of area beds.
David, thank you very much. Anything else for Alex or his colleagues?
Yeah, I was just going to say, so Martin, in terms of the length of stay, nationally we're seeing in this COVID period, all trusts having an increase, so even the best have gone up by about 2 to 3 days. And many believe it's the acuity of kind of patients that they've seen, first time presentations as well, so people not known to services and things like that. So it'd be interesting to see where it settles down. But there is a monthly COVID national benchmarking tracker, and there is some work going on nationally kind of understanding that length of stay. So we've probably been impacted it in the same way as others. So there's probably some national learning as well as local learning that we might be able to draw on in due course.
Thank you, Julian. Okay, shall we, if there's no more questions, shall we move on then to any comments Naomi wants to make on Finance, Investment and Performance Committee?
Yeah, just very briefly, thank you, Chair. Alex has really covered the finance position. I think as we look forward to year end with a relatively small deficit, which Alex has reported, you know, will be covered, we would be well to consider that a good outcome given the volatility and the uncertainties over the last 10-month period. So hats off to the finance team. Looking ahead slightly, the team are starting to now think about a cost improvement framework, and that will be matured over the coming weeks in anticipation of the new planning cycle emerging, which will be delayed, and that's a good thing, because the NHS England are recognising that that there's still a way to go to deploy at least the certainty that they can financially for the system, until we kind of re-emerge into something that looks like the planning cycle that we had historically. I think just two things to pull out of the last FIP meeting, which are of interest. One is the review of the Vets High Intensity Service, which, as you may recall, was awarded to Solent under circumstances which were not entirely to our liking. But more importantly, we kicked the tires, reviewed the circumstances under which that came about, and really the sort of net outcome was a learning that our ability to build relationships, in particular with commissioners, we could up our game a bit there, and that becomes highly relevant when we look at other strategic services that we would want to win going forward, and that in particular relates to the 0 to 19 public health nursing service. So that was a really good outcome to review something that had happened historically that we can learn from and take forward for improvement. And then the only other thing that I'd like to pull out is the appointment of the Wellbeing Guardian, which is happily our good friend Mark. And we had a very engaging conversation about the principles attached to that appointment, its purpose and its criteria. And Mark was very insightful in terms of his commentary around that appointment, in particular wanting to ensure that we deploy preventative measures for our staff, because the whole framework for it seemed to be much more reactive rather than preventative. So of course that's very much within our wheelhouse, and I feel certain that we're going to make a fist of that. So all to the good. Any questions?
Anything from Naomi? No? Naomi, thank you very much. Excellent. Can we then move on to strategy? Item 9, the COVID-19 recovery plan report. Catherine.
Yeah, thank you very much. I'll take the report as read. I mean, I assume it's no surprise to anybody on the board that recovery has now been paused because we're in the midst of wave 2. I did actually stand down the recovery programme board in January and February to allow operations to just focus on what they needed to do. I am intending to have the recovery board meeting again in March, but it will be a strategic conversation rather than operational. And probably just to share the 3 areas that we're thinking of focusing on are the capacity and demand model, which helps us understand the impact on our waiting lists. We have the reducing health inequalities plan on the agenda. And what we've also started is a conversation about how we restart services, bearing in mind that our staff are now absolutely totally exhausted, and we probably can't go straight from managing wave 2 into full on recovery. So we want to have a sensible approach to that. As in wave 1, we've had to move some staff around to make sure that those critical services continue. And as in wave 1, where we've been able to continue planned appointments via remote means, we've been able to do that. I think a positive, although we've talked about waiting lists increasing, actually some services have been able to clear some of their waiting lists in this time. So it's very varied picture across the piece. I think that gives you an update on since the report, but very happy to take any comments or questions.
Okay, Mark.
Yes, Catherine, the report was very good and thank you for that. The one question I have is, are you comfortable with the level of understanding and communication that is being conducted by the Trust with our patients and service users so that they have a clear understanding in terms of the service provision and what is happening? And the reason for the question is, coming out of the governor's meeting last week, there did seem to be a level of misunderstanding or ignorance on their part in terms of what was happening. And I just wondered whether the same might be true with our patients and service users.
That's very helpful feedback, actually, Mark. So during wave 1, because all the services are so different, it became a service-led communication. So that in terms of Marcoms, the comms team, we designed a set of templates for letters to patients, but then each of the services had to populate the content of that because, of course, it was quite different. So that's probably really helpful feedback in that. I couldn't honestly say we've been as proactive during the second wave because, of course, we've had to go back. So let me take that as an action. I had clocked that we need to do some comms when we move into recovery because, as I say, it might look quite different for different services. But let me take that as an action and check what we've done around, the pausing of wave 2 services. Thank you for that.
Thank you.
Chris.
Just a quickie, really, Catherine, and again echoing what Mark said about the report. History tells me that as soon as the NHS gets over should we say, a crisis, a capacity-related crisis, that it tries to get everything back to normal as fast as possible, and quite often the casualties of that, I find, can be some of the sort of people side of things. And I'm sure that as soon as anybody calls things normal again, then we're going to be back to normal NHS planning cycles, we're going to be back to this, that and the other, and a clamour to restore all services, and without saying that there could easily be a wave 3 and a wave 4, but there could easily be a wave 3 and a wave 4, and somehow we have to balance into that, don't we, that we have a lot of people who will have exhausted themselves from November through to March. So how on earth do you manage to, if you like, combine those conflicting priorities when you're thinking about recovery?
So, and thank you, Chris. That's exactly one of the reasons why I started this conversation at the Recovery Programme Board. I wouldn't be surprised if a piece of national guidance came out expecting us to move, I think that was it, near normal pre-COVID levels ASAP. But I think as an organisation, we need to set some principles about what we expect our staff. So the conversation that's starting to come back is that, yes, some services will need a break, but not all services. Yeah. So it's going to be a matter of identifying those services that most need just a bit of time to recalibrate, while other services have been delivering, for example, just remotely, are probably very well placed to move at pace going forward. So bearing in mind that there may be national guidance that will stipulate X, Y and Z, as a trust, I think what we want to do is set a principle that where possible and where it's needed, we give permission to those, to the divisional directors and the localities to have a look at their services and make a decision about what's prioritised in terms of the pace of coming back online.
Thank you.
Catherine, thank you very much. I think we could sort of move on to your other paper, the status report on strategic initiatives, which, as I read it, says that most of the important ones are progressing. And indeed, we've got a very important people strategy and equality strategy coming up. So is there anything you wanted to pull out particularly, or?
No, it was exactly that message. Despite people who support the strategic initiative plan being pulled into supporting COVID, we have actually managed to move forward all the mission critical and most of the importance, and we have actually managed to move 7 of our initiatives over to business as usual or close. So actually, despite where we are, it's a pretty positive message coming back.
Thank you very much. Thank you, Catherine, and thank you to all your colleagues for all the hard work. It's very good. If we may, I'd like to move on to the item 9.2, the people strategy and equalities, diversity and inclusion strategy. Alex, I think you're going to speak, but I welcome Jane Nicholson and Natalie Zacharias as well.
Thanks, Martin. So our vision through these strategies is to be outstanding for everyone at Berkshire Healthcare. These are the final strategies that we're bringing forward for board approval and final comment. And the key actions here we've got in Jane's cover paper to agree the strategies. We want to publish them. They're really important for our people and for others to understand the good work that we're going to be doing through these strategies over the next few years. And I would just reflect, we haven't had a people strategy before at the Trust, and it is brilliant to see this come forward, and in strong support and golden thread, the equalities, diversity and inclusion strategy is an absolutely key enabler around that vision for outstanding for everyone. So I want to thank Jane and Natalie for attending board today, and thank them and their teams for all their work on these strategies, because they set the frame for us to go forward. I'm going to hand over to Jane just to introduce. I think we are going to take the papers as read, but Jane, over to you.
Okay, thank you very much. Yes, as Alex said, the strategies have both been in development for some time, and a number of you will have seen this in different committees or within board as we've been developing this. So I'd like to talk specifically about where we are now with the people strategy, and then I'll pass over to Natalie to talk about the final version of the ED&I strategy, and then welcome any questions that you may have during the conversation on either of those. So you've seen, I think, before the people strategy in a visual format. What's new today really is 2 things. What we have presented is a written narrative to accompany the visuals. now we've worked very closely with the Marcoms team, and I will say thank you to Catherine and her team, for the support that they have given us there to try and make sure that that we've got the right tone of voice, and that the strategy that we're developing, the people in the ED&I strategy do link together and link back also to the work that Catherine has been doing on the overall trust strategy. So we now do have a narrative, and what we have now done is talked in some depth around the key performance indicators or the measures of success for each of the work strands within our people strategy, and particularly I would like some feedback around whether you are comfortable with the KPIs, whether you think they're crisp enough, and whether you think there's any more work that we need to do to tidy up those KPIs before we finally launch this in the more public arena. So both the next steps for both of these strategies in terms of communication is that we will launch these in line with the launch of the overall trust strategy. And again, communication, the Marcoms department are talking to us about how we plan the communications of this. So it's likely we'll launch the trust strategy first, and then we will follow on with the people and the ED&I strategies. We'll probably launch them at one of our all-staff Q&As formally. And then we will publish the documents on both our website and our own intranet. And then my plan with the comms department, what we're beginning to evolve is, can we go out and do a series of engagement exercises to take the strategies out to our people, and also link that in with any engagement that we're doing at the same time around staff survey and staff survey results. And then in terms of actually monitoring our progress, so we will be taking this through the strategic people group. So monthly we will be looking at progress against various work strands there, and then there will be a review quarterly with FIP, and then we're suggesting certainly in the first year that we have a 6-monthly review with board on how we're progressing with this. So if we're losing traction in one area, we can decide what we want to do about it. If we're making good progress, then that's great. We can report on any good progress that we're making. And I just want to make sure that that timetable feels comfortable for you as a board. I'm going to pause there. I think that gives you an introduction, and just open up to any questions around the people strategy. I think, Chris, you've got your hand up already.
Yeah, well, I just wanted to say how beautifully presented it was, and how easy it was to, should we say, yes, we have seen iterations as it's gone through various committees and through board, but the way this is set out is outstanding in terms of what we're going to do and the deliverables. In the short run, I'll be honest with you, I think it's I think the timelines you set yourself are extremely challenging, given the other circumstances. But I just wanted to say how, what an enjoyable read it was, and how clear it was relative to what we've been trying to, get to over the last 6 months or so.
Thank you. Thank you.
Thank you, Chris. Naomi.
Yeah, thank you, Jane. And I echo Chris's comments that you've matured this beautifully over the last few months, and it looks, in great shape. I just want to explore a bit further with you the whole performance management of it. And my thinking is this at its highest level is that you've developed some KPIs which look entirely sensible. You've got in mind the resources to deliver those in a timeline. So my question is about the interface between, between actioning all this stuff and how it might be delivered in relation to QI. And has it been given any thought in relation to the performance reporting mechanism? So what I'm after here is, the thinking behind that. And are we going to try and integrate any of that stuff, or do you envisage performance managing the delivery of the people strategy in a different way?
Okay, there's good questions. I've already got a conversation now with the, with Catherine's team, with Neil and Catherine's team, Neil Merton, to ensure that we actually have a proper project delivery plan behind this, and that we're using our project methodology to ensure that we are reporting on this and monitoring it through those means. QI is going to be built into everything we do. So we've already started to have a conversation, for example, about business improvement, and we'll be using QI principles in order to look at how we can do some of those business improvement pieces. So yeah, absolutely, all of the work that we're trying to do, where it's appropriate to do it, we will be using the QI methodology.
Thank you, Jane. I'm very relieved by that answer.
Yeah.
Sorry, could I just follow up, Jane? Sorry, I didn't quite catch, but in terms of our normal performance reporting, we know, which is about falls and phone restraint and finance and all that sort of stuff, which is very clear. Is it going to be in one of those parameters?
Yeah. So.
Or we're going to have to delve deep. My slight worry is that we know, how visible is it going to be to the board that we're on track?
Yeah, okay. And I think this is why I'm talking about these metrics and how comfortable you feel with the metrics as a board group, because some of them obviously are going to be annual metrics because we're going to have to measure them manually. Others will be able to give you more of a progress report. So, for example, turnover, we can give you, we already measure that on a monthly basis anyway, and you'll be able to see that through our normal reporting measures. Some of them, for example, the well-being challenge that we give ourselves is linked back to the staff survey, so we won't really know whether we've achieved that until we get the next staff survey result. So it is, I'm afraid, going to be a little bit of a mix, but I think we've had a number of quite deep conversations with the leads of these work strands to try and work out which is the best way we can measure some of these things, and that's the best that we came up with. Hence why we were also saying that rather than doing an annual report to the board on this, we do a 6-monthly report to assure you that for some of the activities that, for example, we won't be able to measure for a year, such as well-being, we can at least tell you what we're doing, what activities are taking place, how those are being received, and getting a sense of whether this is beginning to land. We can certainly do some other DIC checking in between, so pulse surveys, for example, if we need to, but we can evolve that as we go through. I will also reassure that these are not going to be the only measures sitting underneath this. The teams themselves will have a number of their own metrics that they will be measuring on a smaller, more tactical scale as well.
Thank you, Jane. Alex is...
Yeah, supporting our people is one of the key elements of True North, and part of the process will be to identify key metrics we may want to bring forward from the people strategy into that level. So we've got that kind of strategy deployment view and pulling out into the performance reporting at board level.
Thank you very much. I think it's one of the consequences of doing something really important, Jane, is that boards want to have a clarity about how we're doing, and this is a really important issue for us. So if you can bear with us, if we, as a board, we struggle a little bit to get our requirements about reporting clear, but we clearly want to hear about it. I just got a couple of comments, if I may, on language, and forgive me if I'm getting rather sort of philosophical here, and I think it's a great paper, so thank you very much. This is really good stuff, and I love the outstanding for everyone as a strapline. I think it's really great, and I'm pleased to see the more quantitative targets. I just wonder, some of them in your paper, so for example on page 143, the ambition, we by 2023 we have eliminated the differential experience between staff with identified inequalities in comparison, etc. A very clear statement. I think if I looked at the one before on page 142, reduce the number of disciplinary cases, it starts to get into slight lack of clarity about what we're actually going to do by when. And my comment is not to try and be too picky about it. It's just that I think in these sorts of things, we have to have a message when we go out to staff, which is absolutely clear and simple. We don't want to get into sort of somebody asks a question and it all starts to unravel. I think we need to be very clear about what it is we're really aiming for, however challenging, whatever it is. And I'm just slightly nervous that some of the wording looks a bit like sort of legalese, but that may be just a question, maybe just a drafting matter. And when you're familiar with it, it's easy to overlook. But I just urge you to keep them as simple, as clear as possible. I think it's a great plan. The only thing it seems to be silent on, unless I missed it, is about helping women and BAME staff getting into more senior posts in particular. And that has come up in some of the discussions when I've been listening to staff across the trust, that those sort of things do come up a bit. And so I think we just need to somehow make sure it's factored in. I'm not trying to rewrite the paper. It's a great paper, but I just think there's something we don't want to forget about, if I can suggest that. But otherwise, really, really great.
Okay, yeah, thank you for the feedback. I will go back. You know, it's interesting, isn't it? You put the paper in, then when you reread it again on the day, you through somebody else's eyes, you do see something. So I'll have a look to see if there's a way that we can just tidy up a little bit of the language on one or two of those. Some of the messages we're trying to convey are that we've got this target, but actually that isn't where we think is where we want to be. And it's trying to create that sense that this is where we want to go to initially, and then there's some more, and that sometimes complicates the language. Martin, I will reassure you that we are going to do some work on career progression. That comes very much under the ED&I strategy, and the work that Natalie's strategy will be leading. So that's why you're not seeing it in the people strategy, because it's very much linked into the ED&I strategy.
Jane, thank you. I think just to conclude before we move on to Natalie, it's a great paper, and thank you very much for the leadership you've shown in this. Good stuff.
Well, thank you equally. I know that a number of you have engaged in this at various points, and I really do thank you for your thoughtful comments and responses, because it has helped us to, iterate this and get it to a better place than where we want it to be. And by all means, please, Martin, do take some interest in this. The last thing an HR director wants is that the board isn't interested in the people. So very happy for you to hold me to account for this.
I can assure you we're all interested. I just hope that we don't get in the way, that's all, but we're very supportive.
Thank you.
Shall we move on to Natalie then? Is that okay? And the EDI paper. Natalie, you there?
Yes, thank you. And I will take the paper as read, but use this time to try and bring to light the role of myself and the EDI team in the oversight of bringing together and governance of all of these different strands of work that we've captured as our priorities in the strategy. We're in the very strong and fortunate position for the first time to have a central resource of an EDI team, and so I'll explain some of our critical areas and priorities. For the workforce, our focus is really very much on what we've described as addressing the differentials in experience, and the pieces of work that we'll be supporting are primarily the BAME transformation program that Jerry's leading on. The most immediate piece of work within that is the bullying and harassment and microaggressions workstream that Tunda and Mike are the leads for. Feeding into that, we've started a piece of work at Prospect Park, the health and safety report with hate crime has shown that 74% of the reported hate crimes last year were at Prospect Park Hospital, and we had a member of staff, NHSP staff, at the end of last year speak up about it. So we've formed a working party to support the operational team at Prospect Park, obviously with David, Jerry, Comms, HR, the EDI team, looking at how we can really make some tangible changes and long-lasting changes for the staff that work there. Supporting all of this work will be the review and offer of our leadership training, really looking at that cultural piece, trying to equip all of our leaders to support their teams with inclusive behaviours and bringing about the work to bring that culture of inclusion and belonging. And the EDI team will support the delivery of that training with the Ready for Change program that Tunda is delivering. He'll deliver it together with Laura, looking at two modules, one on allyship and one on cultural and emotional intelligence. The other key focus for us, which Martin and Jane have touched on, is the differentials in experience with career progression and recruitment. So that will probably be a piece of work that we'll start making some traction in towards the end of year one, a bit of balancing resources and priorities with all of the work that's going on in COVID. We have to be realistic of the expectations on services and teams, but also it's a more complicated piece of work to really analyze the data and understand where we're best to target our efforts. At the moment, the data is actually showing that in terms of promotions around the organization, in the last 12 months, we've actually achieved parity across all of our BAME workforce, but what we still have is a gap. So we really need to understand how we can best address and close that gap. The critical areas for focus for our patients and communities will be on health inequalities and really doing some work around reducing those health inequalities. So our team will be working with Catherine on her piece of work on the COVID health inequalities, but it will also be a broader piece of work supporting the outstanding work that Cecily does and working with the East services to help them to catch up with having that really good level of engagement with their communities and third sector organizations. We're going to, as an EDI team, we'll be able to strengthen that work through restarting our EDS, our equality delivery system work, where we'll be able to assess ourselves and track our progress over time. Doing some more work on the accessible information standard to make sure that our services are equally and consistently accessible for disabled patients, and building on the work that's had to happen for phase 3 for the recording of demographics for our patients, so that we can accurately capture where pockets of patients with protected characteristics may not be accessing our services or where there might be inequalities. So I hope that explains how we'll tackle by priorities what seems to be an enormous piece of work on our strategy, and I'll take any questions.
Any questions or comments, please? Aileen.
I just wanted to give a really quick bit of feedback, because I know we had the discussions at the previous boards. The plan on the page to me is really, really clear, and you've now talked through everything that goes behind it, so I think that's really good. And then the targets, I was quite concerned about the language last time about the differentials, but all of that's been really cleared up, and it just reads so much better than it did in the previous variant. So I just wanted to say thank you for reflecting all of that feedback in there.
Thank you.
Anything else? Naomi.
Yeah, Natalie, quickly, and this might sound like I'm pulling something out, you know, of a body of work that is holistic and has all the elements, but the piece about staff that experience bullying and harassment and abuse from patients and relatives and the public, you know, this is a problem, obviously not just for our BAME staff, but it's for our staff across the piece.
Yeah.
And I have, and it every time I look at those words, it makes my blood absolutely boil. I have to tell you, it really, really does. I just that the very thought of people turning up for work and having to be in that kind of position, it just is incredibly irksome. And I know that we have deployed a few things to support that effort, and I think that's a piece of work that's ongoing, like CCTV. But I'm also aware of the issue in relation to patient capacity, which is highly relevant. But I think I've seen statistics that reveal that many of these patients do have capacity, and the public and their relatives do have capacity. So I'm just challenging you and the team to go deeper. I just feel very passionate about this, that we could be doing more. You know, we're not the only institution that experiences this. The police do, clearly, you know, people who work in railway stations do too. And I just wonder if there's something we can learn from outside.
Yeah, absolutely. And thank you, Naomi, and absolute assurance that we all share your views and concerns, and have an absolute commitment to immediately make real changes in this.
Thank you, Natalie.
Natalie, I just got to thank you very much, and thank you for the evolving drafting of the introduction, which I think is very helpful. I just wonder about publication. What do we do in terms, what's our policy in terms of publication of EDI statistics generally? I know we do RES and WDES, but under the Equality Act, I think we would normally expect to publish against all protected characteristics key data, wouldn't we? Is that something you would recommend or not do, or is there any reason why not? Rebecca, I'll just say one more thing before you reply, which is that the danger is if you concentrate on a certain set of protected characteristics, is that something may well pop up in an area that you really worry about, but you only wish you'd looked at it before it the problem emerged. It's not about saying that some areas don't require much more effort because there's a bigger problem, and we know that is the case, for example, with our BAME staff, but it's just if we don't have the data, there's a danger we might find something which, unpleasant is happening just because we're not looking, if you know what I mean.
Yeah, absolutely. And a really important question and a good point. I guess it's twofold. There is the stuff that we are required to publish, like our RES and WDES data, and some organisations choose to publish via their annual reports. Things like their gender pay gap as well on their websites. I think in part the equality delivery system does some of what you're describing, and though it's optional to participate and to publish your assessment and your findings for that too, and that's across a number of different goals. The equality delivery system focuses on workforce and patients too, so we could certainly choose to be, which I think you're describing is more transparent with the work that we're doing. But I think it's more than just what's on the website, Martin. I think we've made a commitment through this strategy to really make sure we're communicating back to all those communities that we're engaging with in a better way. We've done really well in listening to them and hearing what they say, certainly with the work that Cecily's done. But as an organisation, we haven't done our bit in going back to those communities and letting them know what changes we've made and what we've heard and what we plan to do. So I think it is our intention to do a little bit of all of that.
Very good. Thank you, Natalie. Any other questions or comments from the board? Okay, just before I hand back to Alex, if he wants to say anything, just to say, I think on behalf of all of us, to Natalie and to Jane, this is a really good piece of work. It has our full support, absolutely, and I think certainly the non-executive colleagues who may not be so involved day to day are very willing to do whatever we can to support the agenda. So thank you very much indeed. Alex, did you want to say anything at the end?
No, thank you, Martin.
Okay, in which case, thank you very much to both of you, Jane and Natalie.
Thank you. I'll probably drop off now if that's okay with you.
That's fine, yeah.
Thank you, me too, thank you.
So we get on to corporate governance, item 10, councillor governance update, where we had a joint meeting the other day, two good presentations on QI and MSK for Berkshire West. I think went down well. And I continue to discuss with governors about how to handle governor meetings in the future post-COVID, and what we do about our AGM, what we do about recruiting more diverse governors and members, so to make sure we represent the county, and that's I think that's ongoing and it's fine. I've got nothing else to say unless someone wants to raise anything, or unless Julie tells me I've forgotten something. But well, okay. Annual health and safety report, David, item 10.1.
Thanks, Martin. Yeah, I'll take the paper as read. I mean, it's the statistical review of a number of areas. I think the ones I would pull out from the summary really as focus going forward is obviously RIDDOR regulations have become much more important. We've done a lot of review and work recently around the new guidance that's come out from the Health and Safety Executive around what's reportable and what isn't. Done a series of training and sessions for our teams, and there's quite a lot of activity around that at the moment. I think the physical assaults on staff, even though we've seen a reduction, a decrease from last year, remains obviously critical, along with harassment and bullying and some of the other factors. So that will remain a key area of priority and focus, and it's one of our True North metrics. And then fire continues to be a very high priority in terms of the risk of fire, managing that, making sure that we've got the training and all of the other safety factors in place. But hopefully the rest of the report reads for itself, but happy to take any questions.
Thank you, David. Important report. Mark.
Yeah, David, thanks for the report. I was just a little bit concerned, obviously, as you just mentioned yourself, the 4 fires, 3 of which were due to arson. Whilst you say we've got the training in place, and a lot of effort has been made by management, I know, over the past year to increase those conformance levels, which has been achieved in a number of the wards. Some areas like Rowan and Orchard Ward still fail to consistently get up to that level. And the fact that we are prone to arson, probably more than some other trusts in terms of acute, etc. I'm just wondering how you can provide assurance that we will get up to those target levels and not be vulnerable to a potential fatality in the future.
Well, I can't give you 100% assurance, obviously, Mark, but it remains an incredibly high priority. I think we're reviewing these figures every day by ward, by individual, and we're looking at that level on individual compliance. And we're doing reviews after every fire around what happened, what worked well, what didn't. We're in the process of doing that at the moment for one that we had earlier this year to make sure we can learn any lessons, make improvements, which we can always do after every incident. I think there's been good progress made over this year, despite COVID and everything else that we've got going on around compliance on wards. And I think some wards are riskier than others. So one of our community wards is on the first floor. So that's one that is more important that we ensure that people know what to do in the event of an evacuation, which would have to be over a rooftop, as well as how that would be managed. I think at Prospect Park, the 2 older adult wards are less risky around fire setting. Fire setting is happening on our adult wards rather than on our older adult wards. That's where we put the increased fire safety rooms, and we're doing work around fire doors, fire closures, as well as training. So I think we continue to do everything we can think of, everything we can. With the level of turnover and agency staff, I think it's something that we will have to maintain vigilance on continually. It's not something that we can ever say that we've got fixed. And obviously the numbers of those that are trained will move on a day-to-day basis. If someone doesn't do their training, you only need 1 or 2 people on a ward not to have been trained, and then you're not achieving your target. That's the level of impact of the numbers that we have on a ward when you're looking at percentages. So we continue, the assurance I can give you is we continue to have it as a very, very high priority to ensure what you've described doesn't happen again.
Thank you.
Thank you. Any other comments or questions? Thank you very much. Audit committee minutes. Chris, anything you wanted to say or take questions on?
Yeah, I mean, as usual, I'll take questions. I'll draw just a couple of things out. The deep dive that we performed this quarter was on the progress of the EUPD project. Couple of reasons behind that. Well, I suppose 3 reasons. Firstly, I knew that Minno and his excellent team would be able to do a great job in terms of it, and that's always a good thing to do, I think. But also our decision about 2.5 years ago not to increase our physical capacity was predicated by a general view, not just EUPD, but a general view that we could continue to innovate, change services, and make ourselves less bed reliant. And as I said, EUPD was an important element of that. So checking in and making sure that we were doing what we said we would was important. And secondly, being aware that QI was the, should we say, chosen technique for the work that was being done. I felt that drilling into it a bit was probably helpful, not only from understanding the progress over at EUPD, but taking broader assurance around QI. So you know that was the rationale for it. I've asked for, and you've all seen the excellent presentation that we took significant assurance from. You've seen it. It's also been to governors now, and the feedback that I've had from one of those in particular was that he felt very well assured by the paper and the process and all those sorts of things. So a very good piece of work from Minu and the team. The rest of the meeting was probably quite plain vanilla. An introduction to the Caldecott responsibilities that the audit committee is going to be assuming, normal updates from counter fraud, internal audit and external audit, where the, should we say, dreaded start of the year-end planning process started sort of, should we say, to sort of creep into thinking and getting into some of those things. And we rounded it off in literally the last few minutes of the meeting by completing the review of the charitable funds accounts, which led on to an immediate meeting of the trustees to formally approve them. So that was the meeting. Another good meeting, and I'm happy to take any questions.
Any questions for Chris? No? Okay, thank you very much. Shall we move on then to 10.3, the annual declarations of interest and fit and proper persons test report? Julie.
Yeah, this is our annual assurance paper around the fit and proper persons test, and an opportunity for the whole board to look at the declarations which members of the board have declared, and just a request just to let me know when you've got a new declaration or there's anything that does change during the year, just send me an email so we can maintain the register. Thank you.
Any comments, questions, additions? No. We're required to note the register and the assurance provided, so I'm sure we do that, Julie. Thank you very much. I did notice in the somewhere in the draft white paper or something about proposals for the implementation of the CARC recommendations, which I think are still mulling around a bit. So it'd be interesting to see where they land in the end. Okay, we're nearly there. Annual Trust Board meeting planner, Julie.
Again, I mean, this is a living document, so it's just to give you a flavour of what the reports will be. And again, I mean, it will change during the course of the year.
Okay. Everyone happy with the plan?
Martin, just one question on the board planner. I met with Jane and Alex to talk through the health and well-being guardian, and the recommendation that's coming through from NHSE is for an annual report to the board. Personally, I'd put forward a request that we don't leave it a full year, but that we take an interim view in about 6 months' time, just to have a rain check in terms of the direction we're going and for all of the board to be aware of that. Alex and Jane seem to be comfortable with that, but I just wanted to get a feel from the rest of the board if you felt that it might be comfortable to bring something back in the autumn.
Any comments? No. Sounds as though we're probably supportive. Mark?
Thank you.
Yeah. Okay. Any other business, I think, now? Unless, oh, sorry, Naomi.
Martin, sorry.
I apologise.
That's fine. I just a memory jogger there. I just wanted to check in because you and I will be aware that this came up in another conversation about the debarring service check. Julie, is that something that we have to repeat at any point in time? I know when you're recruited onto the board, it's it's a matter of course you go through that, but are you aware?
No, we do it at the start of the process. I think most people have the annual signed up for the annual DBS check.
Do we?
I'll check with HR who organise the DBS checks, but we're only required to check people on appointment.
Yeah. Okay. Thank you.
Thank you, Naomi. Right. Any other business? No? Oh, sorry. Is there someone? No? Date of next meeting is the 13th of April, 2021, and we'll now adopt our normal resolution to exclude the press and public from the remainder of the meeting. Thank you very much. Now, we've got our in-committee meeting. How much time do people